Welcome back to your break. I think that some good networking time. Of course, there will be more time. It's during lunch. Uh, for this next session, you have a panel, and I'm really delighted to welcome two individuals who bring very different perspectives to this conversation. First, we have Cris Ross. Cris is a venture partner at Aegis, and he has served as the CIO at Mayo Clinic, CVS Health, and Hopta. So he's been everywhere. He has spent decades at the center of how technology actually gets implemented at scale and where strategy meets quality. But what makes Cris especially compelling is that his perspective isn't just professional, it's deeply personal. He's a 2-time cancer survivor and patient advocate. And with that, he really brings a lens on AI and digital transformation that's grounded in what it feels like to move through the system, not just how it functions. So I want to welcome Cris Ross.
Thank you.
And then Dr. Steve Parente. Many of us know Steve. Steve is a professor of finance and the Minnesota Insurance Industry Chair of Health Finance at the Carlson School, as well as Associate Dean of the Carlson Global Institute. He's an economist whose work spans from academia to assessing the real-world impact of insurance design and health technology to health policy. In Washington, D.C., Steve previously served as an economist in the Department of Health and Human Services, and then in the White House as an economist on the Council of Economic Advisors from 2019 to 2021. So he has a very unique vantage point as well on how ideas translate into national policy decisions, and how payment policy and economics and incentives ultimately shape what gets adopted, scaled, or left on the cutting room floor. So in our conversation today, we're going to cover a lot of ground. So we're going to try to get through all of it. We're going to focus on 4 areas. 1 is data, 2 is the use of AI in revenue cycle management, price transparency, and then the use of AI to empower patients. So we're going to try to cover all that ground. It's a lot. Okay.
Go.
Yeah, there we go. So for each of these, I'm going to set a little bit of context, and then we'll jump into the questions. We all know that AI and generative AI and large language models require vast amounts of data to work. But in the US, our healthcare data is fragmented and hoarded. Epic, as we know, controls large amounts of the EHR data that's available. Steve, you had said in an article, quote, Epic data is in a moat. They are, just for some data points, Epic is installed in 42% of hospitals. That represents 55% of hospital beds. And so somewhere between Epic and their customers, as well as other EHR vendors and their customers, there is a structural bottleneck to sharing information. So that's the context for this section. So Steve, you have argued that without broad data sharing, AI simply can't reach its potential in US healthcare. So where is the bottleneck? Is it the EHR vendors, or the providers themselves, or somewhere? Is it stuck in HIPAA, right, because of data sharing? Where is it?
Kind of all the above. So I think people have actually had me as professor too, and I talk about the issue that one of the things that makes this industry so unique is monopoly rights. And the last vestige of monopoly rights, whether physicians with licensure, insurers for scale economies, is basically data. Data is an asset to many firms in healthcare. Sometimes it can help them make money. Sometimes it can actually be held because of risk management issues. We're more of a lawyered up society than most others as well. So the reason I think that we have an issue is that the insurers themselves hold a tremendous amount of data in terms of just claims data. No one likes to talk about that as essentially medical records information. Most physicians will say garbage in, garbage out. Of course, if it's garbage in and it's submitted, it's fraud, but that's a separate issue. But what I would say, it's okay to clap for that. But what I would say is that on the EHR front to Epic, yeah, I mean, basically, Epic has done an incredible job, Judy, the CEO, of really creating effectively a Bloomberg terminal for healthcare model. Meaning that for those that know, like if the world is pretty much entirely digital with internet components, but if you're getting an Epic system, you pretty much install it for billions of dollars in a major healthcare system for your healthcare system. There are some relief valves to move the data back and forth, but for the most part, it stays together. And so why does this work for AI? The AI models that are capturing everyone's attention right now are essentially large language models. Anything that comes in from literature, as well as coding, all comes together, process, looks for pattern recognition, puts it back together in your own voice. What we're missing is the clinical data piece that comes into those large language models. And I'm not talking about journal articles, I'm talking about all the different nuances from CT scans, from MRIs, from basically all the different variables for people to come back together. And if we can't get that bigger than a 3 million person hospital system to a 330 million person country, we have a problem.
Okay, so your answer is that it's with if there's bottlenecks everywhere, but
right.
You're zooming in on the EHR vendors as being the source of the bottleneck.
The vendors are, yes, but it's also the institutions.
Okay.
I don't necessarily think that large healthcare systems are, that fond of having this data be shared as well.
Fair. Okay. So Cris, you've been at large healthcare institutions. From your perspective as you run IT in big organizations and you're now an investor, do you think data control is a competitive advantage worth protecting in today's environment?
So I'll agree with the critical things, which is that data is necessary and data is scarce. But in other respects, I would respectfully take a contrarian view.
Love it.
Yeah, I figured you'd like that. So, HHS reported that in 24 to 25, the number of records exchanged via the TEFCA framework went from 10 million to 500 million. It's a 50 times increase in 1 year. There are many people here can raise their hand and say, well, I tried to get my records from one healthcare system to another and I ran into these challenges, and that's true. But for the most part, data is moving much more freely and much more openly under a regulatory regime which has moved in the direction of APIs in a standard fashion with a standard container. Where do we see stickiness? Well, look, I've been doing this for a long time. In 2006, I joined Minute Clinic, this little small organization, and it was fundamental to what we were trying to do that we needed to get data from a sore throat visit for a patient to their medical home. And I thought this was going to be easy. Oh my God, did I get schooled? There was no transport mechanism, there was no standards, there was no vocabulary, there was literally nothing. So together we've been building these frameworks over the last 20 years or so, and I think at this point interoperability is becoming increasingly a solved problem. Does that solve the problem of scarcity? And does that solve the problem of sufficient data to do what we want to do in AI? I would say not yet. We have, we've gotten, the score has gone from like 1 to 9, but the problem is that the measurement stick goes to 100.
Sure.
If what we want to do in AI. But in terms of being able to move records in a meaningful way for patients to accomplish most clinical care, yes, there are still points of stickiness and frustration, but for the most part, I think it's a solved problem.
Okay, so what I'm hearing is that the technology problem is almost solved, if not solved. There's a lot more data that is moving and exchanged, but not enough based on Steve's perspective.
Totally.
Okay, so we're sort of all in the same ballpark. The question is, are we moving enough data to be competitive? Because Steve, you've also spent a lot of time in China. You work with a lot of students there, et cetera, with an MBA program. And so that's where the government controls everything, including the hospitals and the data. So, we don't want to copy what China does. That's not going to work here. But are there lessons that we can learn about how they're using all their data to advance their AI that would be beneficial to us?
I mean, it's hard because they have a system in place where they more or less have a federated national health insurance system, and then with that, all the hospitals are sort of, unless they're private, forced to sort of comply in that space. And at the same time, they also have a very robust private system that is very much aware of what it needs to do with the government to basically still operate in China. And they understand that the data is valuable, and they're also plugging it into, another place where this is going to be for drug development, for basically to go to, they're trying to corner the market right now on phase 1 trials. And that type of clinical data is going to be really important to do that type of work, to scale it and to find out all the things that are going to lead you much more easier to a phase 2 trial. The concern is that we as a society put a lot of value, maybe this is generationally different between, say, Gen Z and millennials and baby boomers, on data privacy, right? So one thing I think everybody should know is like the P in HIPAA is portability. It's not privacy, even though people think of HIPAA from the privacy pieces that come after it, rules and regs. In China, for better or for worse, folks just take it for given that privacy is a luxury item and not typically something you can have. It's an autocratic regime that largely has market capitalism driving it, but that is part of its ethos. And the data sharing elements are really forced upon them to basically operate differently. In the US, we have far more rules and regs on ownership of the data.
Yeah. I want to transition to something that's being debated right now in the federal government, between the federal government and the states, and that's that in December, President Trump issued an executive order to essentially create a national uniform approach to AI in healthcare. Approach to AI, not specifically in healthcare, but it will affect healthcare by being able to preempt state regulations. So, Cris, from your perspective, can you talk about your lens on whether we should have a national, consistent AI approach because we have so much data crossing state lines, or whether or not we should let states regulate themselves? Like as a CIO, as a patient, could you just talk about how you see that?
Yeah, as either of those roles plus an investor role, what I would say is having a harmonized environment is helpful in being able to move technologies from place to place. What I would probably say is that requires, however, that we have the right federal or national approach. I think we moved very strongly from AI needs to be regulated because it's potentially unsafe. Let's proceed as fast as we can, but no faster than is safe. That was kind of the Biden view. And we've now gone to a view that says AI is a competitive asset or weapon, and let's deregulate AI more generally. Frankly, I think that both of those poles, neither of those poles represent where we really want to be, which is, I think, an enablement, but with either self-regulation or some form of safety controls. And I don't think we've quite gotten that right. So in the absence of that, states are saying, holy smokes, we're scared about what this AI monster is going to do to us. I think they're wrong, but there's reason for concern. An executive order doesn't override state legislation at this point. Right. Those laws still exist. And privacy laws are different from state to state, right. And that causes some challenges as well. So, Steve's doing work in China. I do a lot of work in Europe, in particular in France. They have a homogeneous environment. There's a lot of things that are challenging in France, but one that is not, and one that is an enablement, is they do have a sensible, middle of the road, let's be safe, but let's enable these technologies kind of viewpoint. And I think that gives them an advantage.
Yeah. So that executive order came out in December. I believe in March there was a uniform framework that was presented.
Right.
Of course, that doesn't make it law either. But Steve, how do you think this is going to play out?
Well, I think the point of saying that it's going to be Trump 2 is basically very deregulatory is definitely true. I guess the question's really going to be when this really gets picked up by the market, what it will want to do with it or not. And then as part of this, the thing that excites me about this space is that, on the one hand, you might see that FDA might get involved depending upon what bots and AI do with the data. What is more exciting to me is actually 1 or 2 states that are basically saying, we're going to actually try to become the Delaware in terms of a C Corp of like the rules and regs, and think about it really carefully. So state in particular that's come to mind is Utah. So Intermountain has worked pretty aggressively in that space with the state to more or less say, like, here are the ground rules. So on the one hand, it's sort of dereg, but on the other hand, it's a little bit also with a little bit of federalism, saying if we do this right, and we, Utah, demonstrate how this can work with a variety of vendors, first using Intermountain, but then let it distribute beyond just the other states Intermountain connects with. The thought is, why reinvent it in the same way that we have basically charter laws for C corporations in Delaware that we all accept, but don't really worry about having everybody be incorporated in every single state.
Yeah, Godspeed to Utah and Intermountain. I mean, that's exactly what we ought to get to.
Yeah.
Totally agree.
I'm going to switch gears because we have a lot of topics to get through. I want to switch to using AI and revenue cycle management, which gives me total license to talk about prior authorization. So I had to get there somewhere. I wanted this whole meeting to be about prior authorization, but Pinar wouldn't let me. And the reason I want to bring it up in revenue cycle management is that prior authorization is at the center of revenue cycle management, and it's at the intersection of access to clinical care and the economics of an institution. So, see, we were talking earlier about the fact that we were having a little bit of a debate about, yes, prior authorization's been done for years, so what's different now? Well, it's being done more now, and one of the reasons that I understand is that it's so much less expensive for a payer to expand their prior auth list because of automation. So in my world, it used to cost between $45 and $60 for a nurse to review a request. Now it can be pennies to just a few dollars. That efficiency means they can do more of it. Actually, I'm going to start with you, Cris, because I want to ask your perspective on something. So you've been at United Behavioral Health. You've been at Mayo. You've been on both sides of this. What are the different perspectives on this PA issue?
So I really liked your conversation with Sachin with the idea of having one person make a judgment and then someone overruling. It seems to be kind of nuts. Makes sense to me. And I know that as a patient, I really want my doctor to tell me what they think is appropriate. And I would like their judgment to prevail, just to be honest with that. The challenge is when I put on my old hat at being at United Behavioral Health, we were responsible for ensuring 30 or 40 million people with behavioral health, mental health, and substance abuse kind of policies. And when utilization review would come, there would be the sort of anecdote that was always given was, a clinician that would say, the way to solve this adolescent's deep-seated mental health problem is to go to a ranch in Utah where she can ride horses and be with therapists. And it'll be an intensive program, and it's $25,000. And you'd go back to the policy, and you would say, where is the horse ranch in the benefit plan? We don't know, right? So it's sort of a reasonable person does an interpretation of what was intended when a contract was made between the employer and the health insurance policy about what should be paid. And I don't mean to be flippant with that example because I still have a great deal of respect for and affinity for what happens in behavioral health. But at that time, it was very much an unknown, somewhat unregulated space where the difference between the best providers and the worst providers was vast. That is closed to some degree, but there's still a lot of variation. So, in my mind, the way that this is going to happen is sort of like the difference between statute law, what a legislature writes, and case law, which is what judges decide. And if we can have a way to have systems communicate with each other, like, what about this treatment plan? Well, the policy is kind of unclear, so this is what's happened in the last 42 cases, and here's the variations, and does it fall within? If we could find a way to have agents speak to each other and have a reasonable conversation in a more or less real time, and then give advice to the clinician that says, hey, the thing that you're doing is kind of on the boundaries of what's typically done. Let's ask some questions about this patient, and let's have, in some ways, an agentic conversation where AI could help the clinician and the patient. To me, that would be the perfect world.
Yeah.
Well, I'm sitting with my patient, with my physician, and the physician finds out, we might have some trouble getting this covered. Let's talk about it. I don't think that that's a wild dream. I think that's well within in view.
Yeah, that seems achievable. So AI can either streamline a very inefficient process in PA, or it can make a bad process worse by just scaling it. And the large payers made a voluntary commitment to try to make the system easier to navigate. Steve, how do you think that is going to play out with, what do you think Congress is going to do with its oversight of prior authorization? What should they do? How are we going to hold everybody accountable to making sure that it doesn't get in the way of appropriate access?
Yeah, I guess so. The question, I guess, is if Congress is looking at this, to what extent that they want to put the genie back in the bottle would probably be the most aggressive thing. So I before being an academic, I think, Archelle, you know this, I used to work for a Blue Cross Blue Shield plan in upstate New York. It was one of the first ones that was really went in the managed care away from the indemnity insurance. And I remember, if you will, all the nurse reviewers and everybody else that was there. But there was also another part of the job that I had, which was I think every first-time employee that had a master's degree got this job. You were chair of the exception fee committee, and so you basically worked with IT, the nurse reviewers, and everybody else like that to more or less say, like, here's a new procedure, something new we're going to put into place. Do we put it up for medical review, basically prior auth, or not? And then, or do we just let it coast through the system electronically? What concerns me about what you're describing, what United or others are doing with AI and prior auth, is essentially letting it coast through the system if it hits certain criteria, or just stopping it. And the human element of what medical review is supposed to be is being left out. So to your question about Congress, the question is, will you put the humans back? In other words, the AI might say this, but basically there's going to be a pile that sits on still a human, because AI in medical care is supposed to basically augment. It's not supposed to decide, and it sounds like it's deciding. And that's if that comes up in a congressional committee, they will push back on that, and that might re-level the playing field. I do like the idea of having the bots sort of fight it out and then get to a human, but that makes it expensive for healthcare systems that can't afford to do that, to have a relatively decent bot that can go to war with essentially a big insurer company bot to be capable to do that.
So you said the word deciding, and that's a great segue to my next question for you, which is that not only are there probably areas where AI is deciding, even though they deny it, even though they deny using AI for those purposes, but you have published papers where AI has decided retrospectively what the diagnosis is. Are payers using, tell us what you know about payers using AI to actually change diagnoses on claims, and what we should know about that.
Well, I'm not sure I would call it AI necessarily, because I've been around long enough to think about what we thought of as AI was essentially big data with neural links, 10 years ago. And then even maybe before that, logistic regression to the extreme 20 years ago. So what I would say is that the work that I did back identified something unusual, and it wasn't just United, it was United and Humana, where we had some of their Medicare Advantage claims data. And so again, as I mentioned, when I used to work in the industry, the thought was, when a physician submits a claim or a hospital submits a claim, that's a system of record of what actually is there, the diagnosis, the procedure, it doesn't get changed. What it looked as though some of the plans were doing was actually using their medical review capability to sort of go back and say, that diagnosis code doesn't quite right, let's change it. But the way they changed it was essentially to take advantage of the Medicare Advantage rate system and structure to literally give them a different payment component, just absolutely deliberately.
So you're distinguishing that from risk adjustment. You're saying that it was being used for payment.
It was being used ultimately for payment,
Okay.
and potentially used fraudulently. I mean, I think legally, I think this actually gets there, but it got to the extreme limit of what you can do.
Yeah.
And certainly against accepted practice. The thought was, once the claim is submitted, it's true that that diagnosis code might not stand once you actually see what's going on, but you generally don't have it be changed by the insurer without having the patient in front of you with the doctor to understand what's going on. And to the extent that medical review was doing that, maybe legal, but if the goal was so exactly to get you optimized to the rate structure, because we had a counterbalance, if you had A/B test to show that this exactly optimized 99% of the time a better rate reimbursement for the insurer.
So we don't have to elaborate on this, but we could certainly see how changing the diagnosis could get in the way of AI for appropriate care. I feel like I'm in a presidential debate right now. Let's move to, and you guys are both great candidates. Thank you so much. On the topic of price transparency, let's move to that one. There are lots of, the federal government has invested a lot in new mandates, transparency mandates. Hospitals must publish their negotiated rates, but the jury is still out on the value to patients. So, Cris, you know, I'm not picking on Mayo, it's just that you were at Mayo, you published your prices,
Yep.
and I'll just say you probably said, like every other hospital, like, okay, we published it, follow the rules, good luck. What would it take for this price data to actually be useful to patients?
Well, I don't want to speak too much for Mayo, but I think to be a little bit transparent on this issue of transparency, I think we tried to follow the rules, but I think there was certainly a viewpoint of, we did everything we were asked to do, but boy, nobody's going to be able to make heads or tails of this, which is nuts.
Yeah.
Wearing my investor hat, you know, there's a lot of private capital going into creation of tools to help with this. I have no stake in this company whatsoever. It's not a company that's in a portfolio of either of the two firms I work with. Turquoise Health just did a big Series C raise a while ago. They are very much interpret these, the pricing that exists and what claims are actually paid, and provide price comparison guides to consumers, and it's aimed squarely at consumers. They partnered with New York City Department of Health to create an affordability index to help people make a decision about, in particular places where there's a discretionary item involved. You know, you're probably not going to go to one of these tools if you're on your way to the ED and decide which emergency department you're going to go to, but you're sure going to look at it if you're going to have a surgery done that's elective, for example, or plannable. It is so difficult to say how much is a course of treatment for cancer going to cost. You just don't know. And, or for treatment of a chronic serious condition over a long period of time. How do you know? But you can get within a ballpark within a certain range. And I think that's where some of these new companies developing these tools are going to be helpful in interpreting what the data really means.
Steve, you've said that consumers just aren't ready for price transparency. Do you think they will get ready? What will it take?
Well, we have a survey that, or a colleague of mine, Larry Van Horn from Vanderbilt, and Art Laffer, as in the Laffer curve, did a survey and found that only about 22% of people even realize there's variation in prices for shoppable services, common shoppable services, to begin with. In some cases, the variation is 600%. So I've been doing research in price transparency. I've actually worn 3 different hats in this. When I worked in the previous administration, I was involved with getting the rule process done for the insurers to disclose this data, not the hospitals. We knew the hospital data would be a mess. That's why we went to the insurers, because at least there's standardization with coding that can happen. The insurers did their very best to make the data as, people talk about patent thickets, this is sort of a terabit thicket, make the data as heavy as it could possibly be, so that supercomputers have to basically deconstruct it. But it's, to get it into the hands of the consumers means you have to meet the consumers where they are. So it has to be, to your point, it has to be shoppable services, something that are discrete, MRIs, I just want to check on my knee, I want to go for an office visit. Pricing it for like a cardiac procedure or a CABG is just not, you can get a rough range, but it's all over the map based on prior condition. I will say that I'm so passionate about this that I'm about to go to DC, and I helped organize the BAM case competition.
Thanks for bringing that up.
Yeah. And the case actually is come up with a business plan to get a smartphone app that will be used by 5 million people, 5 million users by 2028 for price transparency, using the data that's available. So there's 7 teams competing right now. We'll see what the best of those results are going to be.
Our team is going to be the best team. So I had a chance, based on your referral, to
Don't bias me.
to preview their presentation as they
Oh,
kick
you're
off.
putting your finger on the scale here.
Thank you for your service.
I mean, it's an independent. Where are you flying to? Where's
I'm flying to DC.
Into
It's being hosted at Michael Ramlett's Morning Consult. So
yeah, I mean, I saw the solution yesterday and I thought it was brilliant. So I wanted to give a shout out to the Carlson MBA team, and we should wish them all good luck as they go to DC on they're going to do great. They're going to do great. But there are really creative solutions
I'm
out
not
there.
allowed to clap until it's done.
Are you a judge?
No.
Oh, okay.
But I'm related enough that I just need to be neutral.
All right, we won't. We'll clap. You don't have to. Okay. Before we run out of time for my questions, I want to get to a topic that's uber important to you, Cris, because you asked us to add it, and I'm glad that you did. It's the AI-empowered patient. So what's your crystal ball on how AI will empower patients? And if I just said to you, well, it's just a more sophisticated version of WebMD, do you agree with that or not?
Well, I think it's all an evolution, right? We know that 90% of emergency department visits have a Google search that happens within an hour before that visit, for example. Right? Pretty well known. We know that 40% of searches on Google are health or wellness related. That's just web searches. And then there's the monsters who are providing advice in the space, WebMD, Mayo, and a few others, that people go to as go-to sources looking for trusted advice in what to do. We're seeing Anthropic and OpenAI both introduce tools that are intended to help you at a more granular level. I will say, raising my hand, I worked with Google twice trying to develop similar tools, and it just did not work in Google's business model for a variety of reasons. To help people understand their records in a confidential way. Upload my records and get an interpretation. Now, I know a lot of people who have tried some of these initial tools, and the results are absolutely not ready for prime time. It might be worth taking a look sort of for grins, but it is in no way yet a substitute for a clinician's advice, is what I'd say. Will it get there? I have no question, no doubt in my mind that it will. And I think one of my reasons for it, I don't know how many people saw a week before last, there was an inadvertent leak of Anthropic's tooling structure, right? Which was huge. I take their answer that it was an inadvertent human error and so on, and it was pretty benign. But the thing that was the most useful about it is most people understand that, generative AI began with large language models, and then now it's involved in different ways. The thing that's important to understand is there is this almost coral reef-like ecosystem of tooling that exists in the generative AI space. It is no longer an LLM that you can ask questions from that's been trained on this sort of bland, everything that's in the public sector. There is tools that check on the veracity of other tools. There are inference sorters. There are memory tools. There's ways to get away from just sort of gradient descent improvement in models. All of these things are working together in kind of profound ways. So I don't care if it's patient enablement or whatever. The hyperscalers are doing things that are so fundamentally transformational that I can't understate how important these times are, right? And I think we are going to get to the point where the guidance provided by these tools will not just be asking questions of an LLM, which is repeating on a probabilistic basis what it learned by scraping public sources. It will be sophisticated inquiry, response, check for validity, understand context kinds of tools that are going to be profound.
So what's your biggest, what are you most excited about, and what's your biggest stay awake issue? Then we're going to ask you the same thing, Steve, and then we're going to go to questions.
Sure.
So I'm excited about, if it's an emergent situation, I really want to talk to a human being for the foreseeable future. But I think about myself as a cancer survivor. So I'm about to reach 5 years, which I'm very excited about on the second round. And at that point, I get graduated from the Mayo Clinic treatment program, which is great, which basically means see you later. And I'm good with that. But what I really would love to be able to know is 3 years from now, when I have a concern, can I ask a reasonable bot, is this something that I should be concerned about? Or I want to avoid recurrence of cancer, or I want to avoid in the future stroke risk or cardiovascular risk. What can I do in my lifestyle to alter my behaviors or do something different so that I can live a healthy life as long as possible? I think the tools will be fantastic for that because I think they will be reliable for that. An emergent situation or a complex situation or a concern that goes beyond just a concern, I'm going to want to talk to a human being for as long as I'm alive. But I also hope that those human beings continue to be increasingly empowered with tools that allow them to have insights and so on. I was so lucky to be treated at Mayo, where the knowledge is so deep. But the doubling rate of medical knowledge measured by number of articles, the doubling rate a decade ago was maybe 5 years. Now it's something like 5 weeks. I don't know how a clinician keeps up with all of that.
Yeah.
So if a clinician can have in their back pocket this hyper-capable version of up-to-date, plus all the tools that are provided in their own tools, like Ask Mayo Expert and things like that are used internally. If clinicians can be empowered with that, and I can get a view on it in a sidecar kind of way as a patient, I'm all in favor of that.
Awesome. Steve, what about you?
So I'm excited about the pace of innovation, the data, some of the dereg that's actually allowed some of the health data to move faster. I'm excited about how this works globally because, like I said, the U.S. may be a little behind, but I think other places it'll give a good competition. The fact that AI is in competition, and the fact that like we talked about that price transparency case, younger generations will, I think, force the issue and question and push against all the things that are sort of accepted norms. What keeps me up at night would be like, is it good enough? And so your cancer survival story reminded me of not my own, but my wife's. My wife's going to celebrate her 5-year survival rate this May, Star Wars anniversary day, May the 4th. So
awesome. July 15th, brother. So I'll celebrate with your wife.
But her story was, my wife's a physician, was chief resident in psychiatry here at the U, and when she thought that she had, it was basically kidney cancer, when she thought she had an issue and went to her primary care physician, he was sort of like, it's not really concerned. And she pushed back and then went to actually a person that she knew when she was training, who had a private practice, said this just doesn't feel right. And ultimately found that she had a 6-inch tumor that was probably about a month or two away from going metastatic. Would AI have done anything differently? With the limited evidence that was there, if it wasn't for her being a clinician to push and almost her personality and her knowledge set, I'm not sure she'd be around. So that's the stuff that keeps me up. How many of those edge cases, and maybe they're not edge cases, will this technology be able to address?
Well, and we know that the tools are going to get more sophisticated. You talked about how there's almost checks and balances being built into how AI is used. They're really pretty good today, and so we know that the big large language models that we all talk about all the time, when they're given all good context, they come up with the right diagnosis, the majority, over 90% of the time. But if a patient puts the information in and uses an LLM, they only get the diagnosis right 50% of the time, not because the large language model is wrong, but because the context that it was given is wrong. So
Yeah.
last question, and then we're really going to go to questions, is what do you think we need to do to get consumers literate in how to offer the right context without sending everybody to medical school?
Yeah, I mean, I do think the smartphone stuff is kind of useful. I think partly is also letting the consumers essentially liberate their own data. So I think we still, as a country, I think just in general have a huge bias toward privacy. We want to have our fences up. We don't want people to see other things. I think there needs to be something that, whether it's pushed through the smartphones and younger generations, to say like, just let this data go. Let it go into the stream, because you never know the patterns that you might see. You don't have to go down the Mayo for the executive physical, though it can be fun. You could just let your own data be seen to see if there are patterns that are already there. And that will help to, and that's allowed. The 21st Century Cures Act basically gives everybody the right to own their own data and let that data go back and be reached into to the insurance companies, to the epics, and let it freely go out. When that moment of liberation occurs and people see that that actually is a game changer, maybe for science or for themselves, I think that will be the moment that gets people excited.
That was an aha moment for me, that we don't need to teach people to be clinicians. Maybe we need to, well, a step, maybe not a perfect step, would be to liberate their data. I love that. Let's open it up to questions. Yes, Shira.
Thank you. Thank you, three. This has been really illuminating. Something I think a lot about, and I'd love to get your opinions, honestly, from all three, is around errors and oversight. Specifically, the thing that I think a lot about is how AI, whether you're talking about co-pilots, agents, any of these, increases the wingspan so much for any given clinical role. And for providers, they are pressed on all sides, labor shortage, reimbursement rules, et cetera. So it's very reasonable and rational to reduce your headcount and to have folks fulfilling multiple roles or doing things faster, right? But that results in the errors that we see in, for example, shows like The Pit even showed this recently, right, with the scribe and the error. And people can say, well, but you know, the attending is going to catch this, or a payer somebody is going to catch this down the line. But the reality, as far as I've seen, I'd love your opinion, is there's no set, really standardized framework for that kind of oversight and review and catching of something in relatively real time or thereafter. And so what I'm wondering is, how do we find a system, or have you seen examples for that kind of review that is sustainable and actually practicable for providers?
So I'd take a shot at it, Shira. I think the answer is within the kind of thing I was talking before in the anthropic environment where there's multiple agents. I think it has to be built into the platforms themselves of the tools that are being created, which is essentially, I'm now going to generate an answer based on best knowledge. Now I'm going to have a separate agent criticize that answer for veracity and look for error in a variety of ways. What I'd also say is we're living in an era where 45,000 people in the U.S. die of auto accidents, but if a autonomous vehicle goes up on a curb, it's still headline news. There is human error and there's machine error, and right now we're much less forgiving of machine error, which is understandable. We don't want the robots to rule us. But I think about a company, and I will give a pitch for this, is one that is a portfolio company with one of the VC firms I work with, and it actually, Mayo was a founder and investor in it, a company called Theater that does surgical vision. And the first time you see it, it looks like magic. It's doing a surgical report by looking at the video, only by interpreting what it's seeing on the screen. And if you compare the report, the surgical report that comes out of one of those transcripts with what a surgical team documents after the fact, usually hours after the surgery, and usually based on a template that they miss oh crap, our template says we always do this, but I forgot to take it out because we didn't do it. The difference between the two is absolutely remarkable. The quality is absolutely higher of surgical documentation that comes out of this video interpretation tool as compared to what human beings do. So I think that we are going to get significant increases in quality. I think the machines are going to make errors. I think the error rate over time is going to be substantially less than what human beings are making today. But I do think that our expectations are going to raise, and that's a good thing, right? So Again, I think the answer to it is to make the tools themselves self-diagnostic and self-healing, and not to have tool A do something else and tool B try and fix it. I think that's the wrong answer.
Thank you. Other questions? Yes.
Chris, hey, I had a question about medical liability and, folks coming in with, AI suggesting that they need something. Like when I'm in clinic, for example, 2 months ago, I had someone come in, I need X, Y, and Z tests. Like I have put in all my symptoms into ChatGPT and it's diagnosed me with this. And this was actually a really easy one because I saw he was in the hospital the week before and had already had all of those. And it hadn't bothered asking him whether he had recently had any of those labs. It just told him he needed to go to the doctor to get all these things done. But I see, other patients who haven't been quite so easily, oh, you've already had those labs. And I think I'm a little bit, for medical liability reasons, more likely to just give them what they want, because if they've come in and say, I'm really worried about this, ChatGPT says this is a risk, even if I didn't particularly think that they need that, I'm more likely to just order it to make them happy. And so it's almost paradoxically adding cost to the system and unnecessary tests because it's so convincible. Like the patient is like, I really am concerned about this, and it will agree with you. I don't know if you have any thoughts on like the agreeability programmed into GPTs.
I'm deferring to the doctor.
You're looking at me.
You're the doctor.
Where that live
Not one for the economy.
I will.
I only figure out damages.
I am happy to defer to either of you, or actually even to Dr. Bruce, but I'll take a shot at it, which is, I'm not a practicing clinician, but I know what that feels like. And I don't think it's a 0-1 sum game. Like, I think you need this, but the patient says I need that. I think that there needs to be time to have a conversation about how are you feeling? What are you very afraid of? What are the most likely things that this really could be with your symptoms? Let's make sure that we go sort of strategically and methodically through this list instead of just ordering everything. So I think that the way that I'd respond to that is, yes, it's faster to just say, okay, I'll give you everything you want. But I think the best intermediate step is to have a conversation that is driven in trust and a method and just a pace that works for the physician and the patient. That's what I would say. Bruce, do you have a?
No, I agree completely.
Okay. I got that one right. All right, let's open it. There was a question right there. There you go.
Chris, I was going to ask you to put your investor hat back on, and we were talking earlier, and we heard from Sachin that payers and providers are just getting inundated. There's the snake oil salesman, there's just tons of entrepreneurs and new companies. What are you telling those early stage companies that you're investing in, how to go about getting pilots, driving outcomes, proof points?
Yeah, I tell most of them, please don't go elephant hunting, because if you get that big contract with a large delivery system or a large payer, they will kill you because the demands will be simply too high for an early stage company. So, my advice is find small to medium scale places where an okay answer is good enough and where your beta product isn't going to hurt anybody at scale, it's not going to make major problems, and you can have a chance to improve it over time. Small scale companies don't like to hear that answer. They want to have a list of all these places that they're doing great places or doing great things. So a suggestion is, do a research project or a pilot with a renowned academic medical center, but don't try to sell them $1 million worth of product because they'll eat you alive. And I'm not usually listened to, but I actually think that's the right course. I'm also asked all the time, well, you are the CIO at Mayo, can't you introduce me to all your CIO friends? And I got to tell you, my friends are all nervous when they get an email or a text from me like, what's he going to try and sell me? So I just don't do it unless I think that there's actually a fit between, I know you're shopping for this, please put these guys on your list. I'll do that all day long, but only where there's an identified need.
Okay. Do we have time for one more question, or we don't have time? Thank you so much, Steve and Cris. Really appreciate it. I love the
Thanks,
back and
Archelle.
forth. I love the shared perspectives. You're wonderful. Thank you very much.
Thank you.
Thank you, Archelle.
Thanks, very fun.